So I want you to picture an architect. They've just been handed the commission of a lifetime, right? They're supposed to design this massive, sprawling public park right in the center of a major city.
Okay, I can picture it.
Right. So this architect sits down at their drafting table, and they draw up this perfectly rational blueprint. They map out the subway exits, the office buildings around the park, the coffee shops, and they connect point A to point B with these perfectly straight, neatly paved walkways.
Very efficient.
Exactly. It makes perfect geometric mathematical sense.
Right.
If you are a purely rational actor, just trying to get from the train to your office,
Yeah.
you're going to walk exactly on this paved paths.
Right.
But then you actually go visit that same part like a year after it opens. And what do you actually see?
Well, you see reality.
Yeah.
You look at these beautiful manicured lawns, and cutting right across the grass are these winding, muddy, trampled dirt paths.
Exactly. People took shortcuts.
Yeah.
Maybe they wanted to walk under the shade of a specific tree, or they got distracted by, I don't know, a street musician.
Or they just blindly followed the person walking 10 feet in front of them.
Right, without even thinking about it. And those trampled dirt paths, in urban design, they're actually known as desire paths.
I like that term.
It's great, right.
Yeah.
And today, we are basically using that concept, this idea of desire paths, to completely reframe how we think about public health and preventative medicine and really just clinical interventions in general.
Because for a really long time, medical policy has been designed by those architects.
Yes.
The ones who just expect us to stay on the pavement, which, represents standard economic theory.
Right. The assumption that we're all perfectly rational dots on a grid.
Exactly.
Yeah.
That we always calculate the optimal route and that we always, without fail, act in our own best long-term interest.
But we don't. I mean, we are human beings navigating a really chaotic, messy world. We walk on the dirt paths.
We really do.
And to understand why we do that, and more importantly, how to actually design health systems that account for those muddy realities, we're doing a deep dive today into Chapter 6.7 of the Oxford Textbook of Global Public Health.
And that chapter is titled Behavioral Economics in Health, written by Jed B. Kessler and C. Yue Zhang.
Yeah, and if you are a medical student listening to this, or a junior doctor, a policymaker, really any practicing clinician, consider this deep dive your companion guide to the text.
Absolutely.
We are going to build a really comprehensive framework for why your patients make the choices they make and, how you can actually help them.
Right. But to build that framework, we first really have to understand the baseline. Like before we can talk about the dirt paths of behavioral economics, we need to thoroughly understand the paved roads of standard economic theory.
Because standard economics isn't wrong, necessarily right.
No, not at all. It's just a very specific, idealized model of human behavior. It basically operates on three core assumptions: that individuals are fully rational, that they are completely selfish, and that they are entirely forward-thinking.
Okay, so let's break down what that actually means in a clinical setting.
Sure.
Let's say you have a patient, right? A 50-year-old guy who has just been prescribed an ACE inhibitor for high blood pressure.
Okay.
He picks up the prescription from the pharmacy, brings it home, and then he just leaves it in the bathroom cabinet. He doesn't take it. Under the strict standard economic model, how does a health economist view that patient's decision?
Well, the standard economist looks at that unopened pill bottle and assumes the patient performed a flawless internal cost-benefit analysis.
Like a supercomputer.
Exactly. The model dictates that the patient calculated the financial cost of the copay, factored in the time it takes to swallow the pill every morning, and weighed the subjective annoyance of any potential side effects.
Right, like that dry cough that sometimes comes with ACE inhibitors.
Right. And then they weighed all those present costs against the future benefit of a reduced risk of a stroke or a myocardial infarction.
And because he didn't take the pill, the model just concludes the math didn't work out in favor of the medication.
Precisely. The model assumes he optimized his own utility. He decided he would rather take the gamble on the heart attack than deal with the daily inconvenience of the pill.
Wow.
And under the strictest interpretation of standard economics, if an individual has made a rational choice that maximizes their own personal happiness based on their own risk tolerance, the government or the health system should absolutely not intervene.
Because leaving them alone is the most efficient outcome.
Right.
But, okay, let me push back on that. Because if a patient's choices are entirely their own business, and they are assumed to be these rational calculators, why do we have public health departments at all?
That is the big question.
I mean, why does the government care if I eat a cheeseburger or skip my blood pressure medication? When does a personal choice actually become a public problem?
Well, That is the foundational question of public policy. Even under this really rigid, rational standard model, there are two distinct scenarios where intervention is mathematically and ethically justified.
Okay, what's the first one?
The first is the existence of constraints.
Constraints, meaning like the patient wants to do the mathematically optimal thing, but there's a physical or financial barrier blocking the path.
Exactly. Let's say our patient did the math and realized the ACE inhibitor was vastly more valuable to him than the risk of a stroke. He genuinely wants to take it,
Right.
but he literally cannot afford the monthly copay. Or maybe he lives in a rural area with zero pharmacy access. He is constrained.
Okay, that makes sense.
So the policy solution here is just mechanical. You remove the barrier, you implement a public health loan, you subsidize the medication, or you set up a mobile pharmacy.
You just pave the road so he can walk on it.
Exactly.
That makes intuitive sense. But constraints obviously don't explain everything. Like, what happens when the patient has the money, has the pharmacy right down the street, and still skips the pill? What's the second justification for public health stepping in?
So the second, and honestly far more complex justification, is the concept of externalities.
Externalities.
Right. An externality occurs when an individual's private decision ripples outward and imposes an indirect cost or an indirect benefit on a third party who had absolutely no say in the decision.
Okay, so it's the ripple effect. Let's trace the ripples of that skipped blood pressure medication.
Sure. If the patient skips the medication and consequently suffers a massive heart attack, the immediate physical cost is borne by him. But think about the systemic costs.
Right, the whole system kicks in.
Exactly. An ambulance is dispatched. He's rushed to the emergency department. He spends 3 weeks in the intensive care unit. He requires complex bypass surgery, months of cardiac rehab.
And the patient rarely pays the true, unvarnished cost of that entire cascade out of pocket.
Never. The whole financial architecture of modern healthcare relies on pooling risk. The massive cost of that ICU stay is absorbed by his private insurance pool, which drives up the monthly premiums for everyone else in his network.
Or if he's on a public health system, the cost is absorbed by the taxpayers.
Exactly. So his private decision to avoid a mild cough from a pill just cost the collective public hundreds of thousands of dollars.
So that's a negative externality.
Right. Because the individual doesn't bear the full financial weight of their own heart attack, they don't factor that massive societal cost into their initial cost-benefit analysis. They basically undervalue the pill.
And the market fails.
Yes. In economics, whenever people fail to internalize the cost they impose on others, the market fails. It leads to socially inefficient outcomes. So the public health system intervenes maybe by taxing unhealthy behaviors to force the individual to internalize those external costs.
We see this logic applied to environmental policy all the time, right? Like, a chemical plant doesn't want to pay for expensive scrubbers on its smokestacks because it saves them money. But then the asthma cases downwind skyrocket, and the local hospital bears the cost. So the government steps in, fines the plant, or taxes the carbon, effectively forcing the plant to pay for the asthma.
That's a perfect example. It corrects the math.
But in public health, we aren't just dealing with negative externalities, right? We also intervene to promote positive externalities.
Absolutely. A positive externality is when your private action generates a massive benefit for society that you aren't fully compensated for. The classic, undeniable example here is infectious disease and vaccination.
Right, like when you get a flu shot or a measles vaccine, you're protecting yourself, sure. But the real public health victory is that you become a dead end for the virus.
You're generating herd immunity. You're protecting the immunocompromised newborn in the waiting room who literally cannot get the vaccine.
And because you don't receive a check in the mail for saving that baby's life, you might undervalue the flu shot.
Exactly. You might think, well, I don't care if I get the sniffles. I'll just skip it. Therefore, standard economics dictates the government should subsidize vaccines or even mandate them for school entry to ensure society reaps those massive positive externalities.
The same goes for medical donations, I'd imagine. Donating blood, bone marrow, or organs postmortem, you are directly transferring health and life years to another human being. It's like the ultimate positive externality.
It really is. But we also have to recognize the hidden positive externalities embedded in just our daily lifestyle choices.
Like what?
Well, when we talk about obesity, diet, smoking, and exercise, it often feels like we're encroaching on purely personal liberties. Like if I choose to sit on the couch and eat potato chips, who am I hurting but myself?
But we go back to the risk pool.
Exactly. If you choose to exercise, maintain a healthy diet, avoid tobacco, You drastically lower your lifetime healthcare utilization.
Yeah.
You delay the onset of chronic, expensive diseases.
Right.
By doing so, you are actively subsidizing the healthcare system for everyone else. Your healthy lifestyle exerts downward pressure on insurance premiums and tax burdens. So public health departments fund anti-smoking campaigns and build public walking trails to encourage those hidden positive externalities.
Okay, so let me summarize where we're at. Under standard economics, we intervene to fix constraints, and we intervene to manage these ripple effects to protect the herd.
Correct.
But if we pull back and look at this model, there is a glaring blind spot here. What happens when we are looking at a behavior that has no major externalities, where the person has absolutely no constraints, where they actively want to make the healthy choice, and they still fail?
And this is where standard economics hits a brick wall. Standard theory simply cannot process a scenario where an individual's intention does not match their execution. If you tell an economist, look, I want to lose weight, I know how to lose weight, I can afford healthy food, but I just keep eating cake. The standard model breaks down. It assumes you must actually value the cake more than the weight loss, and therefore you're acting rationally.
But anyone who has ever lived in a human body knows that isn't true. We make mistakes. We act against our own stated interests constantly.
We do?
And this introduces a third, distinctly behavioral rationale for public health intervention: helping people help themselves.
Yes. This is the realm of bounded rationality. The psychologist Herbert Simon pioneered this concept, basically arguing that humans are not supercomputers. We have limited cognitive bandwidth, limited memory, limited willpower, and we are subject to highly predictable cognitive biases.
So we are rational, but our rationality is bounded by our biology.
Perfectly said.
And the most pervasive destructive bias when it comes to preventative medicine is something called present bias.
Yes, present bias.
I always think of this as the eternal, exhausting roommate dispute between future me and present me.
Oh, that's a great analogy.
Right. Like, future me is an absolute paragon of virtue. Future me wakes up at 5:30 a.m. to jog. Future me preps healthy meals for the entire week. Future me flosses twice a day. And future me consistently contributes to a retirement account. I love future me.
We all love future me.
But present me is the one actually steering the ship, and present me wants to hit the snooze button, eat a donut, and watch streaming video.
That analogy perfectly captures the phenomenon that behavioral economists call time-inconsistent preferences, or hyperbolic discounting.
Hyperbolic discounting. Okay, define that.
Present bias is basically defined as the tendency for individuals to drastically overweight costs and benefits that are incurred today, the present moment, relative to costs and benefits that will be incurred in the future.
Okay, let's unpack the math of that, because it's not just that we value the present more, it's how disproportionately we value it, right?
Think about the decision to go to the gym. It's Sunday evening, and you're planning your week.
Yeah.
You are evaluating Monday morning's gym session from a distance because both the cost, waking up early, physical exertion, and the better cardiovascular health, weight loss, or in the future, your brain evaluates them somewhat objectively.
Right. I look at the math and say, well, the long-term health benefit vastly outweighs the temporary fatigue. I am definitely going to the gym tomorrow, and I set my alarm with absolute conviction.
Exactly. The intention is pure because present me isn't being asked to do any actual work on Sunday night.
Present me is just delegating to future me.
Right. But then Monday morning arrives, the alarm goes off, the temporal landscape is completely shifted, the future has suddenly collapsed into the present.
And now it's cold outside the blanket.
Yes. Now, the cost of going to the gym, the cold air, the immediate physical tiredness, the time lost is happening right now. Because it's in the present, your limbic system flares up, and your brain drastically overweights that cost. It suddenly feels insurmountable.
Meanwhile, the benefit living 5 years longer when I'm 80 is still decades away.
Exactly. It holds almost no psychological weight in that specific moment. The massive present cost crushes the delayed benefit, and you hit snooze.
So I've experienced a preference reversal. I didn't change my mind about valuing my health. My cognitive software just glitched because of how it processes time.
That's exactly what happens.
Right.
And when we apply this to clinical medicine, the implications are just staggering.
Yeah.
It perfectly explains the procrastination we see in preventative care.
Like with the flu shot.
Right. The medical benefit is delayed, and probabilistic, you might avoid a week of misery next month. But the cost is painfully present. You have to leave your house, navigate traffic, sit in a waiting room with old magazines, and experience the acute, present moment sting of a needle.
And present bias ensures that the immediate hassle of the waiting room feels heavier than the abstract concept of immune protection.
Exactly. It makes quitting smoking or changing a diet feel nearly impossible because the sacrifice is always demanded today. The craving is today. The hunger is today.
But the reward healthy lungs, a lower BMI, is always tomorrow. And as the saying goes, tomorrow never actually arrives. The moment you wake up, it's today again, and present bias resets the board.
And we know this is a cognitive error, a failure of execution, not intention. Because of one really fascinating quirk of human behavior, our demand for commitment devices.
Commitment devices.
Yeah. If that individual on Sunday night could sign a legally binding contract that would fine them $1,000 if they didn't go to the gym on Monday, many would actually sign it.
Wait, really?
Yes. They actively want to bind the hands of their future weaker self. Standard economics cannot explain why someone would pay to restrict their own future choices. But behavioral economics understands that they're just trying to outsmart their own present bias.
That is wild. Okay, so let's look at the sheer scale of the damage present bias causes. The Oxford text highlights 3 major clinical arenas where this bias just wreaks havoc on public health. The first is medication adherence.
The statistics cited by researchers like Osterberg and Blesch are incredibly sobering for any prescribing physician. They estimate that roughly half of all medication-related hospital admissions in the United States are a direct result of poor adherence. Half. Patients are diagnosed, prescribed the correct physiological cure, and then they simply fail to take the medication as directed.
That is a colossal failure of the system. I mean, we spend billions developing these miraculous drugs. Doctors spend years learning how to diagnose the illness, and the whole chain breaks because the pill just sits on the counter.
And the financial hemorrhage is vast.
Yeah.
Those specific hospital admissions, the ones entirely preventable by simply taking the prescribed pill, cost the U.S. healthcare system approximately $100 billion annually.
$100 billion.
Yes. Now, a standard economist would look at that and immediately search for a constraint. They would say, well, drugs are expensive. Patients must be rationing their doses to save money.
And surely that is true for some patients.
It is, absolutely, but it does not explain the macroscopic trend. Studies have repeatedly shown that severe non-adherence persists even among patient populations who face zero out-of-pocket costs.
No.
Even when the medication is entirely free, delivered right to their door, patients still don't take it perfectly.
Because present bias doesn't care if the pill is free. The cost isn't just financial. The cost is the present moment hassle of fetching water, opening the bottle, remembering to do it at the same time every day, or dealing with a mild wave of nausea for 20 minutes.
Right.
All of those are present costs that overpower the invisible delayed benefit of controlling your cholesterol.
Exactly. The second clinical arena the text focuses on is obesity and weight control. Flegel and colleagues noted that 68% of Americans are categorized as overweight or obese.
Right.
From a purely epidemiological standpoint, reducing obesity and eliminating tobacco use would yield the most dramatic improvements in global morbidity and mortality. But weight control is the ultimate battleground for present bias.
Which brings us to one of the most revealing economic studies ever conducted on human irrationality. I love this one. The Gym Membership Paradox by Delavigne and Malmendier. This study is like the perfect autopsy of our bounded rationality.
It really is. They looked at the billing records and attendance logs of a major health club franchise. They wanted to see if the financial decisions people made regarding their memberships actually aligned with their physical behavior.
So imagine a typical gym. You have options. You can pay a flat monthly fee. Let's say it's $70 a month, which grants you unlimited access. Or you can just pay a drop-in fee every time you show up. Let's call it $10 a visit.
Okay. If you're a rational actor, the math is simple. If you plan to go to the gym more than 7 times a month, you buy the monthly membership. If you plan to go fewer than 7 times, you pay the drop-in fee.
Makes perfect sense. But what did the researchers find when they actually looked at the people holding the $70 monthly contracts?
They found that the average monthly member went to the gym so infrequently, often just 4 times a month, that they were mathematically losing money.
Wow.
If those same individuals had simply canceled their monthly contracts and paid the $10 drop-in fee at the front desk every time they actually showed up, they would have saved significant amounts of money over the year.
So they were actively bleeding cash for the privilege of not going to the gym.
Exactly.
But here's the brilliant psychological question. Why didn't they cancel? Why do people hold on to these draining contracts for months or even years?
Well, standard economics would say the transaction cost of canceling must be too high.
Hmm.
Maybe the gym makes you mail a certified letter to cancel or something.
Right. They make it annoying.
But Delavigne and Melmandier found that even when canceling was relatively easy, people delayed. The real barrier is psychological. Canceling the membership requires an individual to confront their own present bias.
Hmm.
It requires them to look in the mirror and admit, future me is never going to become the person who works out.
It's an admission of defeat. It's like buying the membership is a form of self-signaling. When you hand over your credit card for an annual contract, you are purchasing the identity of a fit, health-conscious person.
Exactly. Feels good in the present.
But actually getting on the treadmill requires execution, and that's where present bias takes over. You don't cancel because you constantly tell yourself, well, I had a bad month, but I'll definitely start going next week. You are perpetually overly optimistic about your future self's willpower.
It is the ultimate proof that intention does not equal execution. The third major arena the textbook highlights is medical donation, specifically organ donation. The gap between supply and demand here is fatal. Based on 2014 data, there are over 123,000 individuals languishing on the U.S. organ transplant waiting list.
And the tragic irony is that the solution is theoretically abundant. I mean, one deceased organ donor can provide up to 8 life-saving organs. Tissues, corneas, heart valves, the positive externalities are astronomical.
Yet, despite widespread public support for the concept of organ donation, fewer than 50% of eligible adults are actually registered. Surveys consistently show that a vast majority of people intend to donate. They believe it's the moral, correct choice.
But the physical act of registering, navigating a government website, filling out a form, and psychologically confronting your own mortality is a present cost.
Yes, and the benefit goes to a stranger in a distant future after you are dead. Present bias ensures that the form just stays sitting on the desk unmailed.
So we've identified the dirt paths. We know our patients are boundedly rational. We know they're trapped by present bias, suffering from time inconsistency, and failing to execute their own health goals. The central question for the rest of this deep dive is, what do we do about it?
Right. How do we fix it?
How do we build a better park? If patients won't do the right thing for their future selves, perhaps we just need to change the math in the present. Let's look at the first major pillar of behavioral intervention: reward incentives. If the delayed benefit is too weak, let's artificially inject a massive present benefit.
We begin with the standard incentive model. The premise is wonderfully simple. People value money, and they will exert effort to acquire it. If a health behavior is too difficult, you simply attach a financial bounty to it. You pay them.
Blunt force economics. Does it actually work in practice?
Yes, often quite effectively. Sharnis and Nisi tested this with college students in exercise. They took a group of students and offered them a straightforward financial contract. We will pay you $100 if you go to the campus gym at least 8 times over the next month.
I mean, $100 to a college student is a fortune. That completely alters the Sunday night calculus. The present cost of waking up early is now instantly offset by the present benefit of cold, hard cash.
And the attendance rate soared compared to the control group. Furthermore, the researchers were looking for habit formation. They wanted to know if forcing the students to go to the gym for a month would rewire their routines. They did find that attendance remained elevated for a short period after the financial payment stopped, suggesting some habituation, though other literature warns that these artificially induced habits often decay over time.
What about a more deeply entrenched, biologically addictive behavior? Paying someone to lift weights is one thing, but what about paying them to overcome nicotine withdrawal?
Volp and his colleagues tackled this with a landmark study at a massive multinational corporation. They designed a structured financial incentive program for smoking cessation. Employees who smoked were offered up to $750.
$750. That is a very serious financial lever. How was it structured? Because you can't just hand them the money on day one, right?
No, it was staggered to combat present bias at multiple stages. You received a small payment just for enrolling in the cessation program. You received a larger payment if you successfully quit within 6 months, verified by a biochemical test, and you received the final payout if you remained smoke-free for an additional 6 months.
So they were continually dragging the future benefit into the present moment. Don't smoke today because your next payout is only a month away.
Exactly. And the results were profound. The group offered the $750 was significantly more likely to quit and stay quit compared to the control group, which only received standard informational pamphlets about the dangers of smoking. The money fundamentally altered the behavioral landscape.
But we don't always use cash, right? Sometimes giving out cash is culturally inappropriate or logistically difficult, or in some cases, highly illegal. I mean, the National Organ Transplant Act in the U.S. strictly prohibits the exchange of valuable consideration for organs. You cannot buy a kidney.
That's correct. But you can use non-monetary incentives in other areas of medical donation, like blood drives. Lasseter and colleagues analyzed data from the American Red Cross. They looked at the impact of offering small, non-cash rewards, T-shirts, coffee mugs, blankets, or retail coupons.
The classic, I donated blood and all I got was this lousy T-shirt strategy.
It might be a lousy T-shirt, but it works. They found that offering these items significantly increased donor turnout, and it followed a rational economic curve. The higher the perceived retail value of the promotional item, the larger the spike in blood donations.
Though Kessler and Zhang's chapter does raise a critical nuance here. When you see a massive spike at a blood drive because they are giving away a nice fleece blanket, you have to look at the spatial data. Are you actually creating new donors, or are you just cannibalizing existing donors?
The substitution effect, yes. If the Red Cross offers a blanket at a drive on the east side of town, a regular donor who usually donates on the west side might just drive across town to get the blanket. The total aggregate blood supply in the city might not increase as drastically as the specific drives numbers suggest. It's a logistical shell game.
But broadly speaking, giving people things works. Now let's look at one of the most intellectually fascinating non-monetary incentives ever devised. It's a policy applied to organ donation, and it is the ultimate expression of reciprocal altruism. The priority rule.
Both Israel and Singapore have implemented variations of this policy. The architecture is brilliant in its simplicity. If you take the time to officially register as an organ donor, and in the tragic event of your death your organs are made available, you receive a massive present-day benefit. You are granted priority status on the National Organ Transplant waiting list should you or a close family member ever need an organ in the future.
You're essentially buying biological insurance. It completely solves the present bias problem. The benefit of registering is no longer just a warm, altruistic feeling about helping a stranger after you die. The benefit is immediate selfish security for yourself and your loved ones while you are alive.
Early data, particularly from Israel, suggested this mechanism functioned exactly as intended, driving up registration rates. But the textbook authors, Kessler and Roth, conducted critical research into the fragility of this system. They wanted to see what happens when human ingenuity looks for a shortcut. They investigated the concept of loopholes.
Because if there is a system, humans will try to game it. How exactly does a loophole work in a priority organ registry?
Depending on the specific legal and medical implementation of the rule, there could be scenarios where an individual secures the priority status without ever truly paying the cost. For example, an individual might register as a donor, giving themselves priority for years. But upon their death, their grieving family might possess the legal right to override the registry and refuse the donation. The individual enjoyed the insurance of priority, but the public health system never received the organs.
They got the insurance without ever paying the premium. They were free riders.
Kessler and Roth ran laboratory experiments simulating this exact dynamic using game theory. They set up an economic game where participants could choose to donate to a collective pool and receive priority, but they introduced a mechanism simulating that loophole. The results were catastrophic for the system.
What happened? Did everyone just take the loophole?
It wasn't just that people took the loophole. The existence of the loophole destroyed the social fabric of the game. When participants realized that other people were free-riding, getting the priority status without actually contributing to the pool, they became resentful. They felt like they were being played for fools. The priority rule, which was supposed to encourage donation, actually made people less likely to register than if there had been no priority rule at all. It bred deep cynicism.
Which is a terrifying lesson for policymakers. Behavioral interventions are incredibly fragile. You can design a brilliant incentive, but if the choice architecture isn't watertight, human psychology will tear it apart.
That leads us to the biggest limitation of standard incentives. Let's go back to the cash payments.
Right. I have a major logistical problem with Volp's smoking study and the gym study. Offering a smoker $750 to quit is great in a corporate study, but if the National Health Service or Medicare tried to pay every single smoker $750 or pay every sedentary person $100 a month to jog, the system would be bankrupt by Tuesday.
Completely bankrupt.
Standard financial incentives are incredibly expensive, blunt instruments. They simply do not scale to a population of millions. How do we achieve that same powerful behavioral shift without detonating the budget?
This is where we cross the bridge from standard economics to true behavioral economics. We stop using brute force cash and we start using behavioral design. If we know that human beings suffer from predictable cognitive biases, we can weaponize those exact biases to help them.
We hack the irrational brain.
Precisely. Let's examine how the human brain processes risk, probability, and loss. Standard economic theory assumes our brains are perfect linear calculators. It assumes you view a 1% chance of winning $100 as mathematically identical to a 100% chance of receiving $1. The expected mathematical value is exactly the same.
But nobody acts like that.
No. As prospect theory demonstrates, human beings predictably and consistently overweight small probabilities. Our brains amplify tiny chances of winning. It's the peanuts effect. This is the entire psychological foundation of the global lottery industry. People happily buy a $5 scratch ticket knowing the mathematical odds are overwhelmingly against them, because the distant possibility of a massive payout captures their imagination.
So that is bias number one, overweighting small probabilities. What is the second?
Bias number 2 is loss aversion. The psychological pain you experience from losing $10 is roughly twice as intense as the psychological joy you experience from finding $10 on the sidewalk. We are wired to fiercely protect what we already feel is ours.
And the third bias?
Regret aversion. We experience profound psychological discomfort when we realize we made a suboptimal choice that cost us a reward. We hate knowing what we missed out on.
The ultimate fear of missing out. FOMO.
Researchers like Volpe took these 3 specific cognitive biases, overweighting small probabilities, loss aversion, and regret aversion, and fused them together to create an incredibly powerful, deeply cost-effective intervention known as a regret lottery.
This might be the most elegant behavioral hack in the textbook. Let's walk through exactly how a regret lottery works in a clinical setting, like trying to get patients to adhere to their daily medication.
Instead of paying every patient a flat, expensive daily fee to take their pill, the health system enters every single patient into a daily lottery. Every day, a computer randomly draws a name. The prize is substantial, say $100. Because of the overweighting of small probabilities, this captures the patient's attention far more effectively than offering them 50 cents a day.
Okay, so a name is drawn, but here is the hook.
The hook is that you only receive the $100 if the electronic monitoring cap on your pill bottle shows that you actually opened it and took your medication the previous day.
So if my name is drawn and I took my meds, I get the cash. But what if my name is drawn and I skip my meds? Do they just quietly draw another name?
Absolutely not. That would waste the behavioral leverage. If your name is drawn and you skipped your medication, the researchers contact you. They call you and say, "Congratulations, your name was drawn in today's lottery. You would win $100 today. But our records show you didn't take your pill yesterday. Therefore, the money is gone. You received nothing."
That is psychologically agonizing.
Well,
That is weaponized FOMO. You are inflicting the pain of loss aversion and the sting of regret aversion simultaneously.
and it is breathtakingly effective. If a patient receives that phone call, they will likely never miss another pill again. The memory of that lost $100 burns into their mind. They will take their medication every single morning, not for the abstract future benefit of cardiovascular health, but to purchase daily psychological insurance against the torment of missing out on the lottery.
And the beauty of this system is the cost. Because you are only paying out one person a day, instead of paying everyone a flat fee, the mathematics change completely.
Volpe and colleagues utilized regret lotteries for both medication adherence and weight loss protocols. And they found that because it leverages probability, the expected financial cost to the health system was roughly $3 a day per patient. But it generated a behavioral response comparable to much larger, unsustainable flat fees. It's highly efficient choice architecture.
What about commitment contracts? This is another tool that leans heavily on loss aversion, but it doesn't cost the health system a dime.
Commitment contracts are fascinating because the patient brings the financial leverage themselves. Instead of the hospital paying the patient puts their own money on the line. The text highlights platforms like StickK.com, which were built by behavioral economists.
So how does a user interact with a platform like that?
A user logs on and sets a verifiable goal. I commit to losing 15 pounds in the next 3 months. They input their credit card information and pledge a specific amount of money, say $500. They also appoint a referee, like a friend or a doctor, to verify the result. If 3 months pass and the referee confirms the user lost the weight, The user simply keeps their own money. Nothing happens.
But if they fail?
If they step on the scale and they haven't lost the weight, the credit card is charged and the $500 is gone.
And the platform adds a diabolical twist to maximize the loss aversion. You can choose where that money goes if you fail. You could send it to a charity, but the most effective option is choosing an anti-charity.
Yes, an organization or political cause that you find morally reprehensible or deeply oppose. If you fail to lose the weight, your hard-earned money is donated to a political candidate you despise or a sports team you hate.
That is loss aversion on steroids. You aren't just losing money, you are actively funding your ideological enemies because you ate too many donuts. It creates a massive, immediate, present-day cost to failing your diet.
Wolf's research demonstrated that these commitment contracts are remarkably effective at driving weight loss. The challenge, of course, is getting people to sign up for them in the first place, because it requires an individual to be self-aware enough to recognize their own present bias. In some studies, researchers had to offer a one-to-one financial matching bonus just to convince people to put their money on the line.
There is one more behavioral hack in the incentive category that I find absolutely delightful because it doesn't involve losing money or fearing regret. It involves giving in to temptation, but strictly on your own terms. It's called temptation bundling.
This is a direct structural assault on present bias. It was pioneered by Milkman and her colleagues.
The premise is that we have want behaviors, things that provide immense present moment gratification, like eating junk food, watching trashy reality TV, or listening to thrilling audiobooks. And we have should behaviors, things that provide future benefits but present moment pain, like exercising or doing administrative paperwork.
Milkman hypothesized that you could solve the present bias of the should behavior by irrevocably tying it to the immediate gratification of the want behavior. They tested this with college students and gym attendants.
They took a group of students and gave them iPods loaded with incredibly addictive page-turning audiobooks. We are talking about the Twilight series, the Hunger Games, the Da Vinci Code, books engineered to end every chapter on a massive cliffhanger.
But the critical piece of the architecture was the lock. The students were not allowed to take the iPods home. The iPods were physically locked in lockers at the campus gym.
This is brilliant. The only possible way a student could find out what happens next in the Hunger Games was to physically walk into the gym, unlock the iPod, and get on the treadmill.
They bundled the temptation with the effort. And it worked. The group utilizing temptation bundling showed significantly higher gym attendance compared to the control group. When Monday morning arrived, the present cost of the treadmill was overwhelmed by the present desire to hear the next chapter.
Right.
Now, as with many behavioral interventions, the researchers did note that the effect deteriorated somewhat over time, perhaps as students finished the books or the novelty wore off. But as a conceptual framework, pairing a want with a should is a highly effective, low-cost strategy for physicians to recommend to patients struggling with habit formation.
Okay, we've explored the power of incentives. We've seen how cash, lotteries, and locked iPods can move the needle. But before a policymaker runs out and starts attaching financial rewards to every single health behavior, we need to discuss a massive, flashing warning light in the literature. Sometimes introducing an incentive doesn't just fail to work, it actively destroys the desired behavior.
This is one of the most important concepts for any public health official to internalize, the phenomenon of crowding out. It occurs when an external, usually financial incentive, inadvertently crushes an individual's pre-existing internal motivation.
To really grasp the mechanics of this, we need to step outside of healthcare for a moment. Let's look at the foundational study on this topic by Nizi and Rustakini. The setting is a group of daycare centers in Israel.
The daycares were facing a frustrating logistical problem. The center closed at 4:20 p.m., but inevitably a few parents would arrive late, say 4:15 or 4:3, to pick up their children. This forced the teachers to stay late, unpaid, to watch the kids. The daycare administrators wanted to stop this behavior.
So, relying on standard economic logic, they introduced a fine. They announced that any parent arriving after 4:00 p.m. would be charged a financial penalty added to their monthly bill.
Standard theory makes a very clear prediction here. If you increase the cost of a behavior, the frequency of that behavior should decrease. The fine made lateness more expensive, so parents should arrive on time.
But the exact opposite happened. When the fine was introduced, the number of parents arriving late actually increased, and it stayed high. Why did the standard model fail so spectacularly?
Because the standard model ignored the sociological context of the relationship. Before the fine was introduced, the relationship between the parents and the teachers was governed by social norms. It was a relational contract. If a parent was late, they felt deep moral guilt. They were breaking a social contract and imposing on a teacher who they respected. That guilt was a powerful internal psychological deterrent.
But the moment the daycare printed a price tag and slapped it on lateness, they changed the invisible architecture.
They shifted the context from a social norm to a market norm. Lateness was no longer a moral failing, it was a commodity that could be purchased. The parents looked at the fine and thought, oh, I can buy an extra 30 minutes of premium childcare for just a few shekels. What a great deal. The external financial fine completely crowded out the internal moral guilt. And crucially, when the daycare eventually realized their mistake and removed the fine, the lateness stayed high. The social contract had been permanently broken. You cannot easily unprice a commodity.
This shift from social norms to market norms has profound implications for global health. Let's bring this back to medical donation, specifically the work of Richard Titmuss.
Titmuss was a British social researcher who published a deeply influential book in 1970 comparing the American and British blood donation systems. The UK relied entirely on unpaid, altruistic donors. Parts of the U.S. system at the time paid donors for their blood. Titmuss famously argued that paying for blood might actually reduce the total supply.
Which, again, defies standard economics. If you offer cash for a product, supply should increase. Why did Titmuss think it would decrease?
Because of crowding out. Titmuss theorized that people donate blood because it is a noble, selfless act. It signals to society and to themselves that they are a good person. It provides what economists call a warm glow. It is a civic duty governed by social norms. But if you walk into a clinic and someone offers you $7 for a pint of your blood, the context violently shifts to a market norm.
You are no longer a heroic citizen saving a life. You are a biological gig worker selling your bodily fluids for below minimum wage. The tiny financial reward insults the magnitude of the act. The cash cheapens the warm glow, and so people simply stop donating.
Mellström and Johannesson put this theory to a rigorous test in Sweden. They took a group of subjects and offered them a choice to complete a health examination that was a prerequisite for donating blood. One group was asked to do it purely altruistically. Another group was offered a small cash payment, roughly equivalent to $7 to complete the exam.
And did the cash crowd out the warm glow?
Overall, they found weak evidence of crowding out. But when they stratified the data by gender, the results were stark. Among the female participants, the introduction of the $7 cash payment significantly decreased their willingness to participate compared to the unpaid group. The external incentive crowded out their intrinsic altruistic motivation.
The market norm destroyed the social norm.
But the researchers were clever. They ran a third experimental group. In this group, the subjects were offered the $7 payment, but they were immediately given the option to donate that $7 directly to a well-known children's charity.
Oh, that changes the psychological math entirely.
It did. In that third group, the participation rates among women rebounded completely, matching the high levels of the purely unpaid altruistic group.
Because the charity option neutralized the market norm. It restored the warm glow. You aren't selling your blood for pocket change. You are using your blood to generate cash for sick children. You are a hero twice over.
Exactly. The lesson for public health is that context is everything. Incentives are incredibly powerful, but they must be designed with a deep understanding of the existing social architecture.
And even when incentives work perfectly, without crowding anything out, they share one fundamental flaw: permanence. The textbook notes that in almost all of these studies, the gym attendance, the weight loss when the experiment ends and the cash stops flowing, the behavior eventually reverts to the baseline. We are treating the symptom, not the underlying cognitive disease.
Right?
So let's pivot. If the problem isn't always a lack of motivation, and if we can't afford to permanently bribe our patients, what else is breaking down? What if they just literally cannot remember what they are supposed to do? This brings us to the next pillar of intervention: salience and information.
This requires us to return to Herbert Simon's theory of bounded rationality. Standard economic theory assumes that human beings have infinite cognitive bandwidth. It assumes we can continuously hold all relevant health information in our active working memory, constantly evaluating every potential consequence of every action throughout the day.
Which is an absurd assumption for anyone who has ever walked into a room and instantly forgotten why they went in there. Our brains are frantically busy trying to process a chaotic world. We drop things.
Simon argued that because our cognitive capacity is strictly limited, our brains must take relentless shortcuts to survive. We allocate our attention sparingly. This results in two major vulnerabilities in preventative health: limited memory and inattention.
Let's address limited memory first. The clinical implications here are vast, especially in chronic disease management. You have a patient with HIV who needs to take antiretrovirals every day, or a young woman taking oral contraceptives. The intention is there. The pills are on the counter. But the sheer repetitive nature of the task over years means the brain simply stops registering it as a novel event. They forget. How has the medical field traditionally tried to solve this?
Historically, the solution has been passive reminders. The quintessential example is the plastic 7-day pill box, or blister packaging where the days of the week are printed on the foil.
The idea being that you organize the information for the patient.
Yes, a pill box tells you exactly what to take and whether you have taken it today. But a pill box is a passive object. It relies entirely on the patient's internal memory to initiate the action of walking into the bathroom and looking at the box. If you get distracted by a phone call and never walk into the bathroom, the pill box is useless. It does not penetrate your cognitive bandwidth.
This is why the modern frontier has shifted away from passive organization and toward active reminders.
An active reminder does not wait to be looked at. It forcibly interrupts your current cognitive process and demands immediate attention. The most common iteration of this is the automated SMS text message. Your phone vibrates in your pocket. It breaks your concentration. The action is cued externally.
And what does the data show? Did text messages actually keep people out of the hospital?
Vervola and colleagues conducted a comprehensive review of the literature on electronic reminders. The evidence strongly supports their efficacy in the short term. For example, text message interventions significantly improved medication adherence among adult patients managing HIV. They were also highly effective in public health campaigns, such as reminding parents to bring their children in for scheduled influenza vaccinations.
It bridges the gap between intention and execution by providing a timely spark. But it's not a flawless system, is it? The text mentions some limitations.
It is not a silver bullet. The same review noted that the evidence was surprisingly mixed for women taking oral contraceptives. Some studies showed improvement, others showed none. And more broadly, the major limitation of active electronic reminders is habituation.
Text message fatigue.
Exactly. If your phone buzzes every single day at 8:03 a.m. with the exact same automated message, your brain eventually categorizes this as background noise. You swipe it away without reading it. The active reminder becomes a passive annoyance. It loses its salience.
That word salience is the absolute core of this issue. For a piece of information to change behavior, it has to be salient, it has to jump out of the background noise and seize the brain's attention. I think the best clinical analogy for salience is the difference between a toothache and high cholesterol.
That is an incredibly apt comparison.
If you have an infected molar, the pain is acute, throbbing, and relentlessly present. It screams for your attention. You will cancel meetings, you will drive through a storm, you will do whatever it takes to get to a dentist. The disease itself creates the salience. You cannot forget about a toothache.
But high cholesterol, or early-stage hypertension, is silent. It whispers. It does not cause you any immediate physical discomfort. It demands absolutely zero cognitive bandwidth today. Therefore, it is incredibly easy for the brain to deprioritize taking a statin because there is no immediate salient feedback.
So the challenge for the public health architect is this. If the chronic disease does not naturally create salience, how can we artificially manufacture it? How do we make the invisible visible?
One of the most elegant ways to manufacture salience is by forcing the brain to engage in active planning. Milkman and colleagues demonstrated this with a brilliant field experiment focused on corporate flu vaccinations.
Walk us through the setup.
They worked with a large firm that was offering free, on-site flu shots to its employees. Everyone received a physical mailer that contained the standard information: the dates the clinic would be open, the times, and the location in the building. From a standard economic perspective, every employee had perfect information.
But the researchers manipulated the mailers.
Yes. They randomized the employees into 3 groups. The control group received just the standard informational mailer. The second group received the mailer, but with a small addition: a prompt asking them to write down the specific date they planned to go get their shot.
Just a little blank box that says, I plan to go on blank.
Exactly. And the third group received a mailer prompting them to write down both the specific date and the specific time they plan to go. I plan to go on Tuesday at 10:30 a.m.
Did the employees have to mail this back? Was it a commitment contract?
No. They didn't hand it in to anyone. It was a purely private, personal exercise. But the results were definitive. The group that was prompted to write down both the date and the time had a significantly higher vaccination rate than the control group.
That is genuinely remarkable. We aren't paying them, we aren't threatening them, we aren't even texting them. Just the physical act of filling in a blank box with a pen changed their medical outcome. Why?
Because it forced salience. When you just read, "The clinic is open next week," your brain files that under a vague, generalized intention. I should do that eventually. But when you're forced to pick up a pen and write Tuesday at 10:30 a.m., so
Yeah.
you have to mentally simulate the future. You have to check your mental calendar. Wait, do I have a meeting at 10:30?
Yeah.
No, I'm free. Okay, I'll walk down after my coffee. That microscopic moment of active cognitive engagement cements the intention. It manufactures salience by bridging the abstract future with concrete logistics.
It builds a tiny, personalized paved road right in their mind. Now, what about when the problem isn't memory or salience, but simply a lack of facts? Standard economics assumes we always make the best choice, but we can't do that if we don't know what's in our food.
This is the issue of imperfect information. For decades, public health policy assumed that the primary driver of the obesity epidemic was simply ignorance. People were eating terrible food because they didn't understand the macronutrient breakdown.
The deficit model of public health. If they just knew better, they would do better.
Precisely. And the policy response was legislation. In the United States, this culminated in the 1994 Nutrition Labeling and Education Act, the NLEA. This was the law that mandated those standardized black and white nutrition facts panels on the back of almost every packaged food item in the grocery store.
And did it work? Did educating the public change the dietary landscape?
The historical analysis suggests it had positive, but limited, effects. Studies have shown that the implementation of the NLA was associated with decreased body weight for certain demographic groups, an increase in the intake of beneficial nutrients like fiber and iron, and a slight decrease in overall caloric intake. But as the obesity epidemic continued to accelerate, policymakers realized that grocery store labels weren't enough. People were eating out more frequently.
Which led to the next major informational battleground, fast food and chain restaurants.
Correct. Cities like New York and Philadelphia spearheaded laws requiring large restaurant chains to post the caloric content of their items directly on the menus and menu boards. The logic was clear. If a customer walks into a coffee shop and sees that a seemingly harmless muffin contains 600 calories, that jarring piece of salient information will cause them to reconsider and buy an apple instead.
And did the data support that intuition?
It did, to an extent. Wisdom and colleagues conducted an observational study at a fast food sandwich chain. They found that providing customers with calorie information led to a reduction in total consumption of about 60 calories per meal on average.
60 calories might not sound like a revolution, but compounded over hundreds of meals a year, that represents significant weight management at a population level.
It does. However, to maintain clinical neutrality and fully understand the bounds of behavioral interventions, we have to look at the broader literature. The overall evidence on calorie posting laws is surprisingly mixed. Several large-scale studies have found absolutely no significant change in purchasing behavior after calorie counts were introduced.
Why would someone look at an 800-calorie sandwich and still buy it?
Sometimes it's simply a matter of preference. They want the sandwich and don't care about the calories.
Yeah.
But there's a more insidious psychological mechanism at play, a major limitation of observational studies: compensatory behavior.
The "I was good today, so I deserve a treat" phenomenon.
Exactly. Let's say the calorie menu works at lunch. The customer sees the numbers, feels a pang of guilt, and orders a salad instead of the burger, saving 200 calories. The researcher records that as a victory. But what the researcher cannot see is what happens at 8:00 p.m. That same customer goes home, feels incredibly virtuous about their disciplined lunch, and uses that psychological justification to consume 400 extra calories of ice cream. The information didn't change their total daily intake. It just rearranged it.
So we find ourselves at an impasse. We've tried paying them with lotteries, but that can crowd out internal motivation. We've tried texting them active reminders, but they get habituated and ignore it. We've tried slapping massive calorie numbers on their food, and they just compensate at dinner. If we cannot rely on motivation, memory, or education, what is left? What if the ultimate solution isn't trying to change the individual's mind at all? What if the solution is simply arranging the physical and digital world so that the healthy choice becomes the path of absolute least resistance?
Welcome to the fifth pillar, and arguably the most powerful concept in behavioral economics: context and framing.
This is the invisible architecture that dictates our lives without us ever realizing it.
This is the core of Richard Thaler and Cass Sunstein's Nobel Prize-winning theory, which they popularized as the nudge. The foundational premise is called choice architecture.
Define that for us.
Standard economic theory assumes that the way choices are presented is irrelevant. A perfectly rational person walks into a pharmacy to buy a pain reliever. Standard theory dictates that this person will scan every single shelf, read the active ingredients of every bottle, compare the prices per milligram, and make the optimal mathematically perfect choice, regardless of whether that bottle is sitting on the bottom shelf or hanging right at eye level.
But anyone who has ever designed a retail store knows that is a fiction. If it's at eye level, it sells. If it's on the bottom shelf, it gathers dust.
Exactly. The choice architecture, the literal physical layout of a store, or the digital layout of a website, or the specific phrasing on a medical consent form, fundamentally alters the decision that is made, even if the actual mathematical options remain completely identical. We are intensely sensitive to context.
Let's talk about the most potent weapon in the choice architect's arsenal: defaults. A default is simply what happens if you do nothing. It is the purest manifestation of the dirt path.
Individuals exhibit a massive, incredibly stubborn tendency toward inertia. We overwhelmingly stick with the default option, even if that default was assigned to us completely at random, and even if sticking with it actively harms us.
To illustrate just how absurdly powerful this inertia is, the textbook highlights a study from outside healthcare that is just staggering. It involves auto insurance.
The New Jersey versus Pennsylvania auto insurance study, conducted by Johnson and colleagues, this is a classic text in behavioral economics.
Let's set the stage. It's the early 1990s. Both New Jersey and Pennsylvania are facing a crisis of skyrocketing auto insurance premiums. To combat this, both state legislatures passed laws forcing insurance companies to offer their citizens two distinct types of policies.
Right. Option A was a more expensive policy that retained a full right to sue for pain and suffering after an accident. Option B was a less expensive policy that offered a limited right to sue. The coverage options available to the drivers in both states were fundamentally identical.
So, if you are a standard economist, you look at these two states which share a border, have roughly similar demographics, and face similar driving conditions, and you would predict that the citizens of New Jersey and Pennsylvania would sort themselves into option A and option B in roughly identical proportions based on their rational risk preferences.
That is the rational prediction. But the politicians in the two states made one seemingly minor administrative difference in how they rolled out the forms. They set different defaults.
Let's see if the listener can guess the impact. In Pennsylvania, the legislature decided that if a driver received the form in the mail and failed to actively check a box, they would automatically be defaulted into the expensive, full right to sue plan. In New Jersey, the legislature decided the exact opposite. If a driver did nothing, they were defaulted into the cheaper, limited right to sue plan. What happened?
The result defied all rational economic models. In Pennsylvania, where the expensive plan was the default, an overwhelming 75% of drivers stuck with it. They kept the expensive plan. In New Jersey, where the cheap plan was the default, only 20% of drivers actively took the effort to switch to the expensive plan.
That is a 55 percentage point difference. Millions and millions of dollars changing hands, not because people carefully evaluated their legal risk tolerance, but purely based on which box an anonymous bureaucrat had pre-checked on a piece of mail.
It perfectly isolates the power as the default. The options were identical, the populations were comparable, but the architecture dictated the outcome. And we see this exact same terrifying inertia applied to critical healthcare decisions.
The textbook details research by Handel on health insurance markets, specifically looking at employer-sponsored PPO plans and Medicare Part D prescription drug enrollment.
Handel analyzed an insurance market where the pricing structures of the plans shifted significantly from one year to the next. In fact, the prices changed so drastically that some people's existing plans became strictly mathematically dominated.
Explain what mathematically dominated means in this context.
It means that no matter what happened, whether the patient was perfectly healthy all year or ended up in the hospital for 6 months, they were mathematically guaranteed to lose money by staying in their current plan compared to switching to a newly available plan. It was a purely irrational choice to stay.
So surely these rational adults logged onto the portal and switched plans to save their money.
No. Handel found that a staggering 89% of those individuals stayed in the money-losing plan. Why? Because their employer system was set up to automatically renew their current plan if they took no action. The default was to stay. And 89% of people took the path of least resistance, bleeding cash in the process.
Why are we like this? Is it just laziness? Standard economics might argue that the transaction costs of switching are too high, like finding your password, reading the confusing PDFs, navigating a clunky HR website.
Transaction costs certainly play a role, but behavioral economists argue the barrier is far more psychological. It's a combination of factors. First, Bounded rationality and inattention. People are busy, tired, and simply don't have the cognitive bandwidth to decipher complex insurance jargon during a 2-week open enrollment window, so they ignore it.
They close the tab and say they'll do it tomorrow, present bias again.
Exactly. But it is deeper than that. We suffer from profound status quo bias. We have a deeply ingrained psychological preference for keeping things exactly the way they are, simply because the current state feels familiar and therefore safe. Any change feels inherently risky.
And closely related to that is omission bias.
Yes. Omission bias is the human preference for inaction over action, especially when outcomes are uncertain. Psychologically, if I actively log in, change my insurance plan, and then I get sick and realize the new plan doesn't cover my specific doctor, I feel intense, crushing personal regret. I did that to myself. But if I do nothing, if I just let the default roll over and the plan is terrible, I feel slightly less responsible. I blame the system. We use defaults to shield ourselves from the emotional weight of making a bad choice.
Which brings us to perhaps the most consequential debate regarding choice architecture in global public health: the organ donation registry, the battle between opt-in and opt-out.
This is the ultimate test of default effects. Historically, countries like the United States and the United Kingdom have utilized an opt-in system. The baseline assumption is that you are not an organ donor. If you wish to become one, you must take an active step. You must check a box at the motor vehicle department or fill out a form online. You must opt in.
Whereas many European countries utilize an opt-out system, also known as presumed consent. The baseline assumption of the state is that every citizen is an organ donor. If you do not want to donate your organs, you have the absolute freedom to refuse, but you must take an active step to file the paperwork to remove yourself from the registry. You must opt out.
Johnson and Goldstein analyzed the incredible disparity these two architectures create. They published data showing that at the time of their research, the effective consent rate in the UK under their opt-in system was hovering around 17%. Meanwhile, in Belgium, which operates under an opt-out system, the effective consent rate was 98%.
17% versus 98%. The magnitude of that difference is hard to overstate. That is the difference between thousands of patients dying while tethered to dialysis machines and a robust surplus of life-saving organs. And that entire chasm of human life is dictated purely by the phrasing of a single sentence on a government form. The choice is preserved in both systems. Nobody is forced to do anything, but the architecture guides the herd.
Now, a clinician or policymaker listening to this must be aware of the nuances. The textbook chapter does provide an important update on this debate. Some jurisdictions, uncomfortable with the ethical implications of presuming consent, have experimented with a neutral or active choice frame.
How does an active choice frame work?
Instead of a default, you remove the path of least resistance entirely. When you go to get your driver's license, the clerk will not hand it to you until you actively check either, yes, I want to be a donor, or no, I do not. You are forced to choose. Early hypothetical surveys suggest that this active choice model might yield higher registration rates than a standard opt-in system.
But what happens in reality?
Kessler and Roth looked at real-world data from states that implemented active choice. The results were sobering. In practice, forcing the choice did not consistently improve registration rates compared to opt-in, and in some metrics, it appeared to perform worse. Furthermore, there is evidence that when a patient dies and their next of kin realizes the deceased was forced to make a choice at the DMV, the family is sometimes less likely to consent to the donation, perhaps doubting the sincerity of the checkmark. Choice architecture is a highly sensitive instrument. You can easily over-engineer it.
Let's move away from digital forms and look at how we can architect the physical environment, because our brains rely heavily on visual cues and spatial friction. I absolutely love the absurdity of human nature revealed in these spatial studies.
We are highly visually driven, often at the expense of our rational judgment. The text mentions the work of Wansink, who studied how humans perceive volume based on the shape of a container.
The bartender study.
Yes. Wansink demonstrated that both professional bartenders and average individuals will consistently pour roughly 30% more alcohol into a short, wide glass than they will pour into a tall, narrow glass of the exact same volume.
Even though the glasses hold the same amount of liquid.
Because our visual cortex relies on a heuristic that judges volume primarily by height rather than width. The tall glass looks fuller faster, so we stop pouring. The short glass looks empty, so we overpour. If a public health initiative wants to reduce alcohol consumption, they don't necessarily need an expensive educational campaign. They just need to encourage bars to serve drinks in tall, narrow glassware.
You change the environment, and the behavior follows automatically. The cafeteria study by Hanks and colleagues is another brilliant execution of physical choice architecture.
They collaborated with the standard cafeteria to test the concept of spatial friction. They didn't ban any unhealthy foods. They didn't put calorie labels on anything. They simply redesigned the physical flow of the lunch line. They created a designated convenience line.
The path of least resistance.
Exactly. This convenience line was fast, easy to access, and it exclusively offered healthier food options: salads, lean proteins, fruits. If a patron wanted the less healthy options, the burgers, the fries, the heavy desserts, they had the absolute freedom to purchase them. But to do so, they had to bypass the fast line and walk over to the traditional, slightly slower, slightly less convenient serving stations.
They introduced a microscopic amount of physical friction to the unhealthy choice. And what was the outcome?
The total aggregate amount of healthy food consumed didn't actually fluctuate much, but the consumption of the unhealthy food plummeted by 27.9%.
Nearly a 30% drop in junk food consumption, purely because it required perhaps an extra 10 seconds of walking and standing. That is the power of the dirt path. We will almost always take the easiest route.
But I know exactly what a skeptical physician is thinking right now.
Yes, I am ready to push back. I will concede that people are lazy when they are carrying a plastic tray in a cafeteria. I will concede that people don't want to read confusing auto insurance forms. We take shortcuts when the stakes are low, but surely when the stakes are absolute, when we are talking about matters of literal life and death, the human brain snaps to attention. Surely, in a surgical consultation, all these biases evaporate and we become perfectly rational calculators.
It is a comforting thought, but it is entirely false. And this brings us to the psychological phenomenon of framing and the absolute masterclass on human irrationality delivered by Amos Tversky and Daniel Kahneman.
The founding fathers of behavioral economics.
Indeed. They set out to prove that even in life-or-death scenarios, our deeply held preferences can reverse entirely based on nothing more than the specific words used to describe the options, the choice architecture of language. They presented subjects with a hypothetical but grave scenario. The United States is preparing for the outbreak of an unusual disease, which is expected to kill 600 people.
A grim, high-stakes setup.
They then split their subjects into two distinct groups. The first group was presented with two policy options to combat the disease, and crucially, these options were framed in terms of gains, specifically lives saved. Option A stated, if Program A is adopted, 200 people will be saved. Option B stated, if Program B is adopted, there is a 1/3 probability that 600 people will be saved, and a 2/3 probability that no people will be saved.
Okay, let's do the math as a rational actor. Option A is a sure thing, 200 lives saved. Option B is a gamble, but the expected mathematical value, 1/3 of 600, is exactly 200 lives. Mathematically, the two options are identical. How did the subjects vote?
When framed as a gain, as lives saved, an overwhelming 72% of subjects chose option A, the sure thing. They wanted to lock in the 200 survivors. They exhibited profound risk aversion. They refused the gamble.
Okay, that makes emotional sense. Now, what about the second group?
The second group was given the exact same disease scenario, but their options were framed in terms of losses, specifically people dying. Option C stated, if Program C is adopted, 400 people will die. Option D stated, if Program D is adopted, there is a 1/3 probability that nobody will die and a 2/3 probability that 600 people will die.
Wait, let me pause and do the exact math again. If 600 people are initially at risk, and under Option A, 200 people are saved, that means 400 people die. So Option A and Option C describe the exact same physical reality.
They are mathematically identical. Option A equals Option C. Option B equals Option D. A perfectly rational supercomputer would vote exactly the same way in both scenarios.
But human beings aren't supercomputers. When faced with Option C, the cold, hard sentence 400 people will die, what did the subjects do?
They panicked. Faced with a certain loss, 78% of the subjects rejected the sure thing and chose the gamble. Option D.
That is wild. The exact same mathematical reality, the exact same number of bodies in the morgue, but simply by swapping the word saved for the word die, the population flipped from being overwhelmingly risk-averse to overwhelmingly risk-seeking.
This is the central tenet of prospect theory. The human value function is not linear. It is S-shaped and asymmetrical. We are fundamentally risk-averse when dealing with potential gains, But we become aggressively risk-seeking when we are desperately trying to avoid a certain loss. And this is not just a parlor trick for economists. It has profound daily applications in clinical medicine.
The textbook cites McNeil and colleagues, who tested this exact framing effect on real patients making agonizing decisions about cancer treatments.
They presented patients with a choice between surgery and radiation therapy for lung cancer. Surgery carries an immediate acute risk of dying on the operating table, but might offer a better long-term cure. Radiation doesn't carry the immediate operative risk, but might be less effective down the line. It is a complex calculus.
How did they manipulate the frame?
They presented the exact same statistical outcomes to different patients, but changed the wording. When the doctors framed the surgical outcome by emphasizing survival, stating that the surgery had a 90% short-term survival rate, patients were significantly more likely to choose the surgery.
And when they flipped the frame?
When the doctors presented the mathematically identical statistic but framed it as a loss, stating the surgery had a 10% mortality rate, the preference for surgery plummeted. Patients recoiled from the word mortality and opted for the radiation.
The words the doctor chooses consciously or unconsciously fundamentally alter the medical treatment the patient receives. The frame is the architecture. So we've seen how our physical environment pulls our strings and how the vocabulary of our doctors shapes our risk tolerance. But there is an even stronger, more primal, invisible force guiding our choices: the people around us. Let's move into our final pillar of behavioral intervention. Segmenting humanity into isolated rational dots is the failure of standard economics. Behavioral economics understands that we exist in herds. Let's explore social forces.
Humans are fundamentally social animals. While standard economics might casually acknowledge that we care about our reputation, behavioral economics places social forces at the very center of decision-making. By analyzing the data, we can predict 3 distinct ways human beings react to social pressure. 1, we conform to the actions of others. 2, we behave differently when we know we are being watched. And 3, we are highly susceptible to direct requests from our peers.
Let's start with conformity. Responding to the actions of others, which researchers call social information, we use the herd as a shortcut to figure out what is safe. A great analogy from outside of healthcare is the classic hotel towel study by Goldstein and colleagues.
Everyone has seen those small laminated cards sitting on the bathroom counter in a hotel room, asking you to reuse your towel instead of dropping it on the floor.
Right. They usually say something like, help save the earth or conserve water for future generations. And I will confess, they almost never work on me. I'm paying for a hotel. I want a fresh, fluffy towel.
You are not alone. Goldstein tested those standard environmental appeals and found they generated a very mediocre compliance rate. But then they changed the text on the card to leverage social information. The new cards simply stated, 75% of guests who stayed in this exact room reused their towels.
And what happened?
Towel reuse skyrocketed.
Because suddenly, reusing the towel isn't about an abstract concept like saving the earth. It's about conforming to a highly specific social norm. If you drop the towel on the floor now, you aren't just wasteful, you are the weird, deviant person breaking the established rules of the tribe that inhabited this exact space.
Exactly. We rely on descriptive norms, what other people are actually doing, as a heuristic to determine the correct behavior for ourselves. Now, let's apply this powerful heuristic to a major public health crisis: binge drinking on college campuses.
This is a fascinating area because it involves a massive collective delusion. It's a phenomenon called pluralistic ignorance.
Precisely. Studies by researchers like Perkins have consistently shown that college students wildly overestimate the frequency and volume of alcohol consumption among their peers. A student might personally prefer to only have 2 drinks at a party. But because the loudest, most visible behavior on campus is the extreme binge drinking, they incorrectly assume that everyone is drinking heavily.
The perceived norm is vastly disconnected from the actual statistical norm.
And because humans are driven to conform, that student will artificially inflate their own alcohol intake, drinking 4 or 5 drinks, just to match what they falsely believe is the baseline required for social acceptance.
So the intervention here doesn't require lecturing them about liver damage. The intervention is just telling them the truth.
Yes. DeYoung and colleagues studied the impact of social norms marketing campaigns across dozens of university campuses. These campaigns utilize posters, campus newspaper ads, and digital media to simply broadcast the actual, mathematically accurate lower average of student drinking. They put up posters saying, fact, 70% of students at this university have 3 or fewer drinks when they party.
And the beauty of this is how it corrects the architecture. Because the perceived norm instantly drops to match reality, the moderate drinkers feel validated, and the heavy drinkers actually reduce their intake to conform to the new, accurate reality. It leverages the herd mentality for harm reduction, and it is remarkably cost-effective compared to traditional policing or medical interventions.
The second social force we must consider is observation. Image concerns. People behave fundamentally differently when they believe their actions are visible to the community.
It's the reason public donor walls exist in museums. The textbook mentions a study by Harbaugh regarding law school alumni donations. If the university privately asks for money, they get a scattered range of amounts. But if the university publishes a public list of donors in the alumni magazine and categorizes them by prestigious tiers, for example, the $500 club and the $1,000 club, suddenly the donations perfectly cluster right at those exact threshold amounts. Nobody donates $499.
They are purchasing the prestige. Lasseter and Maximise observed this exact same image-driven behavior in the realm of public health, specifically blood donation, in an Italian town.
Wait, I thought we established with Titmus that offering rewards for blood donation crowds out the altruism?
It does when the reward is the transactional cash payment that shifts it to a market norm. But in this Italian town, the reward was entirely symbolic and socially visible. The town awarded medals to donors who hit specific lifetime milestones, say your 10th donation or your 20th donation. Crucially, these medals were awarded in a public ceremony, and the names of the winners were published in the local newspaper.
Ah, it amplifies the warm glow by turning it into a public beacon of civic virtue.
Exactly. The researchers looked at the data and found a massive, undeniable spike in donation frequency exactly when an individual was 1 or 2 donations away from hitting the threshold for a medal. The desire for social recognition, to be seen by their neighbors as a pillar of the community, drove the physical health behavior.
And we can weaponize that fear of being seen in the negative direction, too. The textbook details a political science study by Gerber on voter turnout that is almost frightening in its effectiveness.
It is a stark demonstration of social pressure. During an election, they sent mailers to registered voters. A standard informational mailer reminding people to vote had a negligible effect. A mailer reminding people that whether or not they vote is a matter of public record had a slightly larger effect.
But the nuclear option was the third mailer.
The third mailer physically showed the individual their own past voting record, whether they had voted or stayed home in the last few elections, printed right next to the voting records of all their immediate neighbors on their street. And it included a warning. We will send an updated version of this chart to everyone on your street after the upcoming election.
We are going to tell your neighbors if you stay home. The threat of social shame, of being exposed as a bad citizen to the people you see every day, is intense.
And it generated massive, unprecedented increases in voter turnout. While deploying explicit social shaming in clinical medicine is ethically fraught and generally avoided, understanding that humans are deeply motivated by image concern is vital for designing community health architectures.
Which brings us to the final social force. Requests from others, or peer mentoring. This relies on the concept of homophily, the tendency for individuals to associate with similar people. Because there is a profound difference between who is delivering a public health message. If a 50-year-old physician in a white coat tells a 15-year-old teenager to stop smoking, the teenager processes that as a lecture from an out-group authority figure. It is easily dismissed. But if a popular 15-year-old peer tells that same teenager that smoking is gross, that is processed as a vital social survival cue from the in-group.
That is the exact mechanism Campbell and colleagues leveraged in a massive randomized control trial in Wales involving over 10,000 adolescent students.
They bypassed the teachers entirely.
They did. Instead of having health teachers deliver standard anti-smoking curricula, the researchers identified highly influential students within the social networks of the schools. They trained these specific peer mentors to have casual, informal, discouraging conversations about smoking with their classmates during normal social interactions.
They seeded the social network with the intervention. Did it work?
It did. The schools that utilized the peer mentor intervention saw a statistically significant decrease in the likelihood of students taking up smoking 1 year later, compared to the control schools. Now, the effect did attenuate somewhat by the second year, but it firmly proved the concept. The messenger is just as important as the message.
And this isn't just a strategy for high school cafeterias. The text highlights a powerful study by Long and colleagues that applied peer mentoring to adult chronic disease management, specifically diabetes.
This is one of the most promising avenues discussed in the chapter. Long's team worked with adult diabetic patients who currently had poorly controlled blood glucose levels indicated by high HbA1c scores. They paired these struggling patients with mentors.
But not just any mentors.
Crucially, the mentors were fellow diabetic patients who used to have poorly controlled glucose, but had successfully learned how to manage their disease and bring their numbers down. They shared the exact same lived experience. The intervention simply consisted of these pairs talking on the phone once a week or once every 2 weeks.
Just a conversation with someone who truly understands the fatigue, the diet struggles, the frustration of the disease, and what was the clinical outcome.
The peer mentor group demonstrated massive and statistically significant improvements in their glucose control. In fact, to truly test the efficacy, the researchers compared the social intervention against a standard financial incentive. They offered a separate group of patients a $100 or $200 reward for lowering their glucose.
The ultimate showdown. The social bond versus the cash bribe.
The peer mentoring intervention outperformed the financial incentive. The human connection beat the cash.
That is an incredible finding.
And it highlights the immense promise of social forces in public health. They offer two massive advantages over standard interventions. First, they're incredibly cost-effective. It costs an astronomical amount to pay every diabetic patient $200. It costs almost nothing to introduce two patients and ask them to talk on the phone. Second, social forces offer the potential for a longer-lasting tail of effectiveness. A cash incentive alters behavior only as long as the cash continues to flow. The day the money stops, the healthy behavior often collapses. But a relationship forged with a peer mentor or a newly recalibrated social norm regarding binge drinking can become self-sustaining. It rewires the social environment itself.
Which brings us to the end of our journey through the park. We have covered an immense amount of ground today. We started on the perfectly paved roads of standard economic theory, acknowledging that when a patient's choices generate negative externalities like shifting the financial burden of a heart attack onto the public, or positive externalities, intervention is justified. But then we stepped off the pavement. We explored the winding dirt paths of bounded rationality. We saw how present bias and hyperbolic discounting ensure that our brilliant intentions for tomorrow are constantly ambushed by the fatigue and temptations of today, leading to $100 billion in preventable hospital admissions. We explored how to combat this with reward incentives, hacking the brain with regret lotteries and temptation bundling, while carefully avoiding the trap of crowding out intrinsic moral motivation with market norms. We addressed our limited cognitive bandwidth, realizing that if a disease doesn't create its own salience, we must manufacture it with active reminders and implementation intentions. We marveled at the invisible architecture of context, where defaults, spatial friction, and the linguistic framing of survival versus mortality can drastically alter life or death decisions. And finally, we look to the herd, leveraging pluralistic ignorance and the profound power of peer mentorship to guide behavior without spending a dime. We have learned how to nudge, prompt, and guide a patient into making a healthy choice once. But as Kessler and Zhang point out at the very end of their chapter, the true holy grail of behavioral economics and public health remains elusive.
And that holy grail is permanent habit formation.
Exactly. We can trick the limbic system for a day, a week, or a month. We can lock the iPod to the treadmill. But if you are a medical student studying for your boards, a junior doctor walking the wards, or a policymaker drafting the next great public health intervention, I want to leave you with this provocative thought to mull over. How do you build a choice architecture that doesn't just change a single decision today, but completely, irrevocably rewires the default path for tomorrow? How do we transition a temporary, artificially induced behavioral nudge into a permanent, effortless, self-sustaining habit? That is the frontier.
To solidify the conceptual frameworks we have built today, and to support your active reading of the text, let's transition to our learning reinforcement. I have 8 rapid, single best answer style recall prompts based directly on the chapter. I will ask the question, pause briefly to allow you to formulate your answer, and then provide the correct response and the specific section of the chapter you should revisit for consolidation.
Right, let's do this.
Question 1. Under standard economic theory, what is the primary justification for government intervention in health behaviors when an individual's private actions impose indirect financial or physical costs on society at large? Answer: externalities. You can review the mathematical and policy implications of this in the externalities section. Question 2. Which specific behavioral bias explains why a patient possesses a genuine intention to start a difficult exercise regimen tomorrow, but consistently experiences a preference reversal and chooses to delay the effort when tomorrow becomes today? Answer: present bias, often modeled as hyperbolic discounting. This foundational concept is covered extensively in the behavioral biases section. Question 3. A public health initiative attempts to increase medication adherence by entering all diabetic patients into a daily draw. However, a patient only receives the financial prize if their electronic pill bottle was opened the previous day. What specific behavioral mechanism is this intervention leveraging? Answer: a regret lottery. This elegantly combines the overweighting of small probabilities, loss aversion, and regret version.
Review the designing incentives using Behavioral Economics section for the structural breakdown. Question 4. What is the economic term for the phenomenon where introducing a small external financial reward for a previously altruistic act, such as paying a few dollars for blood donation, shifts the context to a market norm and actually decreases overall participation? Answer: crowding out of intrinsic motivation. See the crowding out section for the analysis of Titmus and related literature. Question 5. A patient frequently forgets to take their oral contraceptive. Which type of intervention actively interrupts their cognitive routine and requires immediate attention, as opposed to simply organizing their pills in a passive container? Answer: an active electronic reminder, such as a timed SMS text message. Review the evidence and limitations of this approach in the limited memory section. Question 6. A country alters its national organ donation policy from requiring citizens to actively sign a registry to assuming every citizen is a donor unless they explicitly file paperwork to be removed. What behavioral concept drives the massive observed increase in effective donor rates under this new system? Answer: default effects, driven by status quo bias and omission bias via an opt-out rule. This vital architecture is detailed in the default effects section. Question 7. According to the framing theories developed by Kahneman and Tversky, patients tend to exhibit risk-averse behavior when medical outcomes are framed as gains, such as lives saved. However, what trait do they predictably exhibit when identical mathematical outcomes are framed as losses, such as lives lost? Answer: risk-seeking behavior. Review the profound clinical implications of this in the framing section. Question 8. College students often engage in heavy binge drinking because they incorrectly believe their peers are drinking at similarly extreme levels. What specific public health intervention utilizes this tendency to conform by broadcasting the actual lower averages of alcohol consumption? Answer: social norms marketing campaigns, which provide accurate descriptive social information to correct pluralistic ignorance. See this section responding to the actions of others.
Keep looking for those dirt paths, everyone.
Here are the details of this episode.
Behavioral Economics. Byline: why we don't always choose what's best applying behavioral insights to improve public health decisions.